our earlier work was concerned with looking at decision-making processes, when you've got to change your strategy in the way that you perform something. We know that the frontal lobes of the brain are involved in that, because if there's damage to the frontal lobes due to injury, for example, or certain disorders such as schizophrenia, one of the symptoms that seems to occur is a degree of mental inflexibility. Even when people are presented with clear evidence that what it is that they're doing is not working, there's a real difficulty in changing their actions. And what we were actually able to show was that when the signal to make a change to the strategy occurred, these particular frontal regions lit up, and that was one of our earlier papers showing that, but this occurred very rapidly. More recently, we've used the methodology, the technique, to look at changes in brain activity in a disorder known as attention deficit hyperactivity disorder. Now, this is still a rather controversial disorder. The so-called incidence, the rate at which it's diagnosed, has increased dramatically from a fraction of 1% 10, 15 years ago in some places in Australia to 9, 10% of boys recently. And overseas, in fact, figures or even higher figures are quoted, which is really quite horrific. While I think that ADHD is probably overdiagnosed, there is nevertheless a real underlying disorder there which affects probably the more severe end of the spectrum. And one of our early works was using this SSPT technique to look at changes in brain activity of children who were diagnosed with ADHD, severe end, and those, a control group of children, while they performed an attention task, just looking at images coming up on a screen and waiting for the target to occur. And what we found were dramatic differences in the organisation of the brain activity. In particular, the control group of children showed at certain points in time, important points in time, a dramatic increase in brain activity in the frontal lobes, decision-making process, planning, which the ADHD boys, they're all boys, did not. Now, very dramatic differences. These were published in the Archives of General Psychiatry in the United States, a very prestigious journal. What was intriguing was that the performance of both groups was actually very little. They were performing on this task, this attentional task, at roughly the same level, even though their brains were doing quite different things. And what this was telling us was that we have within us the capacity to perform various actions using different neural networks, some of which are more appropriate in a more immature brain. What we do know is that, for example, there are certain regions deep within the frontal cortex of the brain known as the basal ganglia that are involved in motor planning of a more, shall we say, not so much simple kind, but over a short time span. And we know the frontal lobes are involved in planning over longer time scales. So your decision as to what you'll be doing next week or what you should be planning now for something in 2 or 3 months' time all involves the frontal cortex. But if I said I'm going to throw a ball at you and I'd like you to catch it, the sort of planning for that could involve the basal ganglia, this deeper process. What we know is that young children up to about the age of 5 or 6, those deeper processes are the ones that are the main ones. And there's a simple test that you can give them where children are told to move their eyes according to a particular stimulus. And the simple test is if you put your hands on either side of the person's head and you say, when I move my fingers, move your eyes to the fingers. It's very easy. Everybody can do that. Even 3-year-olds, up and up. The more difficult task is what's called the anti-saccade task. If I say, now look, when you see my fingers move your eyes in the opposite direction. Now what's fascinating is that from about the age of 6 onwards, the children can do this quite well. Earlier than that, they have real difficulty. The moment they see a movement, there's this reflex to move to the movement, and then they move away again. And it's at around the age of 5 or 6 that they develop the neural maturity, which we think is involved in the prefrontal cortex taking over some of those roles. which enables them to do that. Now, what I suspect is happening is that in the severe end of ADHD, the children, when faced with a thinking task, get ready to do this, are reverting to using an earlier neural system that was more appropriate to a much younger stage. They haven't made that transition to the latter process, the prefrontal cortex. If anything, you put pressure on them in terms of this task and they tend to revert to that earlier version. Subsequently, we've gone on to look at changes in brain activity in response to the most common ways of treating ADHD. The most common way, not necessarily the most desirable, but it's the most common, is the use of stimulant medication. Amphetamine, dexamphetamine, or methylphenidate, trade name Ritalin, is probably the most common approaches. These drugs increase the availability of a neurotransmitter in the brain and the frontal cortex called dopamine. They are the most common treatment for ADHD because it's thought that one of the underlying factors in this disorder is that there is not so much too much activity in the frontal parts of the brain, but too little activity, which accounts for some of the hyperactivity, because normally these frontal parts of the brain are involved in control of behaviour, inhibition, stopping you doing things which you realise there are going to be some unpleasant consequences or undesirable consequences. And what we see is that that lack of frontal activity that we see in our brain imaging in the children with ADHD, severe ADHD, is consistent with that. And these drugs actually normalise some of the change in brain activity. And what we've been doing is looking at the effects of a single dose of this stimulant drug, Ritalin, in children who've been newly diagnosed. And what we find is that depending on the type of ADHD they have, you get completely different patterns of brain activity. And this has led us to the wider issue of ADHD is almost certainly not a single disorder. It's a range of different disorders, different underlying processes, and masquerading as ADHD because the symptoms are rather similar. The main symptoms are lack of attention and hyperactivity. You can have them separated. You can have children who are just inattentive, ADD, without the hyperactivity. But what we find is even just those two subgroups behave quite differently. The brains respond differently to a single dose of drug. And one of the things that we're interested in is, A, trying to understand better what is this disorder, and secondly, trying to tailor the treatment so that it best suits the child. And here we're exploring other methodologies, one of which is a technique known as Neuro Therapy or brainwave training, where you actually teach yourself to change your brainwave patterns. And the other one that we're looking at is changes in the diet with essential fatty acids.